Perfect. Good morning. My name is Stephen Edmondowitz. I'm the Interim Division Director of the Division of Gastroenterology and Hepatology here at the University of Colorado, and I'd like to welcome all of our virtual candidates, as well as all of our in-person candidates for this very special day. This is the 4th annual Dennis Ahnen Lectureship, and as you may all recall, this is the kind of morning that Dennis would have really appreciated, because he would be mingling with all of us, telling us how wonderful life is and encouraging everyone to do an absolutely fabulous job in the rest of their day. So without any further delay, I would like to introduce Dr. Sawadi Patel, who, as you know, is one of our key connections to the Ahnen family, as well as the Ahnen Lectureship, and she is going to introduce our very important guest speaker for today. So thank you very much and good morning.
Thank you, Steve. Good morning. It's wonderful to see everyone here in person, and welcome everyone that's joining us virtually, including our GI applicants. And Steve is absolutely right. These are the moments that Dennis relished. So in particular, I'd like to specifically welcome Dennis's family, his wife, Carol, his 3 daughters, Gina, Meg, and Nicole. It's so wonderful to have you here. Thank you for joining us. So before I tell you about our speaker, I always take this opportunity, somewhat selfishly, to tell some of our new GI fellows, our applicants who are tuning in, but also remind the rest of us a little bit about what we loved about Dennis, Dr. Dennis J. Ahnen. So I always like to tell this story. Dennis was part of my circle before I even knew I had a circle. So as circumstances would have it, I actually went to high school with his middle daughter, Megan, in the back, and we both were on the varsity soccer team together. And so Ahnen was part of my life before I even knew he was part of my life. As many of you who have heard him speak before know, he loves telling people about complex ideas in the form of word clouds. And this particular word cloud he shared a lot, because he said this was his key to success, career success, but really life and family success. And these were all the terms that sort of defined how he lived his life. So let me tell you a little bit about his life. This won't be a traditional review of his CV, but I hope to give you a little bit of an introduction as to who this man was. So he was born in Wakefield, Michigan. And though he considered Michigan home, he was part of an Air Force family, so moved around a lot. And one of the places that he spent a little bit of time was Guam. And it was in Guam that he really developed a love for baseball. And if he would have had it, this would have been his word cloud of success, to be a baseball player. He went to high school outside of Detroit and then went to Florida State for college. And despite wanting to be a pro baseball player, his dreams were dashed and he settled for medicine. He went to Wayne State University and then did his residency at Detroit Medical Center. And then we all were very, very lucky that Fred Kern and Dr. Bill Brown recruited him to the University of Colorado for his GI fellowship. Here as a GI fellow, he developed a very strong bond, initially as a mentor, but then of course, as we all know, lifelong friendship with Dr. Bill Brown. His early work in the research lab was on cell surface proteins in colorectal cancer. Dennis was a purist, and they needed normal controls. Others in the lab proposed just using adjacent normal tissue in patients who had colon cancer, but both Dr. Brown and Dr. Ahnen insisted that they needed truly normal controls. So as research was done back in the day, they decided to colonoscope one another. So Dr. Brown performed a colonoscopy on Dr. Ahnen, and Dr. Ahnen performed one on Dr. Brown. So as a fellow, Dr. Ahnen scoped his mentor and got some normal tissue, perfect for their experiment. Dr. Brown scoped Dr. Ahnen and found a 2-centimeter polyp in his rectum with high-grade dysplasia. Dr. Ahnen was a 33-year-old GI fellow at that time. Of course, Dr. Brown removed that polyp, and from there on, Dennis considered himself a pre-vivor. And he credits Dr. Brown with not only saving his research career, but saving his behind. This is probably where a lot of his passion for colon cancer prevention began. He then went on to Stanford as a research fellow, where his lab established how intestinal oligopeptidases are synthesized and transported from the brush border membrane into the cell. His group published the first report on proto-oncogene abnormalities in adenomas and cancer, describing the relationship of KRAS and colorectal neoplasia. And over time, this is basically what Dr. Ahnen's professional word cloud became. This early work was very, very important and built the foundation for him being recruited back to the University of Colorado, where he built a lab at the Denver VA. His work shifted towards cell growth control, and studying mechanisms of non-steroidal anti-inflammatory medications, particularly Sulindac, on colorectal carcinogenesis. The Ahnen lab really became a biomarker lab for multiple large multi-center studies that essentially inform our understanding of chemoprevention in clinical medicine. This led to fruitful friendships and collaborations with individuals like John Byrne, as well as Bob Sandler, and of course, Pam Rice, who he worked with in the lab for many years. He was also a prolific collaborator in the colorectal cancer family registry, with international relationships with multiple individuals, and here locally, important relationships with our genetic counselors, as well as Jan Lowry, Lainey Lindor. He was a VA doctor and a career VA employee committed to decreasing the burden of colon cancer in the veteran population. By David Lieberman, he was invited to join the planning and executive committee of the VA Cooperative Study 380, which essentially defined how we approach colorectal cancer screening in the United States and really showed the importance of colonoscopy. He also served on the executive committee of the VA Confirmed trial, which is the largest randomized controlled trial in the VA system comparing FIT to colonoscopy. His career was really supported without interruption by VA Merit Awards, the National Cancer Institute. But what we all remember about him was that he was an undying advocate for colorectal cancer prevention. And if you drove down 17th Avenue in March, you could see that there was one home that lit up blue, and essentially the entire street that had these Colon Cancer Awareness Month posters that he, without permission necessarily, put on all of his neighbors' yards. He was a local champion for colon cancer prevention, taking every opportunity to educate the community on the importance of colon cancer screening and prevention. He played important roles at our institutions in helping build our University of Colorado Cancer Center and the prevention arm. He, of course, developed the screening program at the VA hospital and was a key contributor to meeting and exceeding the 80 by 18 goal that many of us in the community have fallen short. He had many advocacy roles at the national, local, and regional level, really emphasizing the importance of policy and advocacy and bringing all of the important work he did at the bench and in research to the bedside and to the community. He was highly active in our professional organization, serving on committees at every level, and also active in international hereditary GI cancer societies, including Insight, as well as the Collaborative Group of the Americas. There are many, many accolades that he received over his career, but some of the ones that were most special to him included the William Beaumont Prize in Gastroenterology by the American Gastroenterological Association, the Lifetime Achievement Award from the Collaborative Group of the Americas on Inherited GI Cancers, as well as the prestigious award from Prevent Cancer. Perhaps what's most telling is how he lives on despite him not being with us physically. Many organizations have dedicated awards in his name because organizations refuse to let his legacy fizzle out. This includes a Genetics and Family History Advisory Council from Fight Colorectal Cancer, a patient advocacy organization that built this council in his honor. In addition, of course, the reason we're all gathered here, this lectureship, to ensure that we all take time to dedicate to colon cancer prevention as part of our GI Grand Rounds and as part of Denver Research Day. And the Collaborative Group of the Americas established an Outstanding Service Award in Dennis's name. This is all very, very telling, in addition to the awards that he received when he was with us. Perhaps what's most incredible is how selfless this man was. Many in this room and many tuning in virtually are well aware of how much he gave us, his time, his expertise, conversations, always interested in our professional growth, in our professional advancement, and even our personal lives. And I have to admit that I was an incredible recipient of this and wouldn't be here today and doing what I do if it weren't for him. I think what's most special is that I was one of many. And it's overwhelming to think about how Dennis was able to do this for all of these individuals. Of all the scientific papers that I showed you in his career, probably some of the most fun things that he told us about were the projects that he collaborated with for individuals here in this room, projects that were completely adjacent to his true interests. For instance, in Barrett's esophagus with Dr. Wani, endoscopy training and education with me. Lots of projects that he was more than happy to mentor all of us on, including one when he was in the midst of treatment. He was having side effects to his chemotherapy, and when most would be at home trying to rest and recover, he approached me. He said, "Swati, find me a gastroenterology fellow. We need to get this out there. I need a GI fellow to work with me and write this up so that the scientific community can learn about what I'm going through, and so it can avoid somebody else having to go through the same thing." Incredibly special. This man had a zest for life. He lived it, and he was a role model for all of us on how to live life. He had balance, whether it was physical balance, mental balance, professional balance, and he was stylish. He was a trendsetter. He not only set standards in the scientific community, but fashion standards. And of course, I love showing this photo of him and maybe taking the first selfie back in the 70s. I think back to a grand rounds that I gave as a GI fellow. This was May of 2012. And so one of the traditions in our fellowship is that if you go to a scientific meeting, we all come back and we share what we learn. And for the fellows, in some ways this held us accountable, that we attended sessions and we paid attention and we presented what we learned to the group. And for my presentation back in May of 2012, I showed everyone how fellows experience DDW. This is my colleague and friend, Dr. Joel Wedd, who's a transplant hepatologist. But I took example from how my role models experience DDW. This is Dr. Finley Mcrae and a sailing trip that him and Dennis took while they were at DDW. And so on one hand, Dr. Ahnen's at the podium giving a very high profile presentation that many are attending. And on the other, he found time to sail with his best friend. Even when he was sick, he insisted on making people laugh. You can see that our faculty here are in stitches laughing at a wry comment that Dr. Ahnen made. Coming back to his secret to life, professional life, personal life, he always loved this really important final reveal, that the most critical part of this word cloud is to marry well. And he sure did. Carol is here with us today. They built a beautiful life, high school sweethearts that shared 50 years of marriage together. Beautiful family, beautiful touching memories over the years. This lovely touching note that Dennis sent to Carol when they were young. They have 3 beautiful daughters, 8 beautiful grandchildren. And although we lost him too soon, and he should be here with us, sharing in all of this, he passed his zest for life not only on to all of us, but of course, generations in his family. I'm very, very honored and lucky for him to have been a part of my circle from beginning to end. And I, whether I have permission or not, have inserted myself into his family. And I'm just very, very pleased that he and Carol and the girls will always be a part of my family. It is a true honor to be able to carry on this tradition, to tell you all about Dennis and take 5 to 10 minutes of our time to remind everyone who knew him and to tell future generations about how important and special this man was. One of the most important things he did for our division was establish this lectureship so we could all take this time to dedicate to colon cancer prevention in his memory. We've had wonderful speakers over the years, including Dr. David Lieberman, Dr. Rick Boland, last year, Dr. Jason Dominitz. And this year, I'm incredibly honored to introduce Dr. Finley Mcrae. He's a professor and head of colorectal medicine and genetics at the University of Melbourne, the Royal Melbourne Hospital in Victoria, Australia. Professor Mcrae has had a career-long research interest in early detection and prevention of colorectal cancer. This all started as part of the Australian National Health and Medical Research Council, where he was invited to be a postgraduate scholar at the Royal Melbourne Hospital. This was followed by an Applied Health Sciences Fellowship at St. Mark's in London. He's done seminal work in how bleeding patterns from colorectal cancers and adenomas underpinned the approach to early detection of colorectal neoplasia through fecal occult blood testing. And this approach has now been implemented at the Australian National Bowel Cancer Screening Program. He's been involved in randomized controlled trials of diet and aspirin and how that can lead to prevention of colorectal cancer. And these trials that he has led have translated into national recommendations on prevention of colorectal cancer in Australia. He is an international leader in the field. He co-chairs multiple important interventions and important efforts, including the international CAP trials, which look at chemoprevention and Lynch syndrome. He's on the steering committee of the Aspirate trial and on the NIH-funded colon cancer family registry. He's a leader in international hereditary cancer associations, including INSIGHT, and most recently has been pivotal in establishing the INSIGHT ClinGen committees to address interpretation of DNA variants in the genes predisposing to colorectal cancer. He's also part of the important prospective Lynch syndrome database international consortia, which is aimed to provide estimates on penetrance in Lynch syndrome. These and multitude other studies in genetics and genomics were recognized through a civil award of the Order of Australia, which he received in 2016. In 2008, he initiated the highly successful Australian and New Zealand Gastroenterology International Training Association, which builds capacity through training across multiple Pacific sites, including Myanmar, Nepal, and has involvement of over 200 trainer members. Probably one of the most valuable of many of these letters next to his name is one that he very endearingly calls DFOD, dear friend of Dennis. He shared this with Dennis's DFOF, dear friend of Finn. So without further ado, I'm very excited to introduce Professor Finley Mcrae, who will be speaking on aspirin, chemoprevention, and colorectal cancer. Thank you, Dr. Mcrae.
Thank you, Sawadi, and thank you, all of you, for coming along 7 a.m. on a Monday morning, and especially to Carol, Gina, Megan, and Nicole for coming along at such an early hour in the morning as well. So, I hope we can. So I've sort of deliberately put a lot of initials after my name, not to boast, but just to point out this is a special day today. Carol's mentioned some of these earlier ones, but I'd like to focus on these two because today is a pretty special day. And the R here in both the FRACP and FRCP brings us close to the funeral in London, because this represents the Royal Australasian College of Physicians and the Royal College of Physicians. So we in Australia are indeed a colony still, although at least under the Commonwealth umbrella, we feel close to what's happening today in London. So I thought I'd just bear that out, because right at the moment, the coffin is moving between London and Windsor. I'd also like to point out, as Sawadi did, these, because I've also had a very strong affiliation with the United States, and that's represented by the AGF, the Fellowship, the American Gastroenterological Association, and the American Society for Gastrointestinal Endoscopy. So I've had very close links with both countries, both continents over my career, but most especially I value the last one, which Swati's mentioned already, dear friend of Dennis's. And of course, this is reflected in many ways. This was just a few years ago when Dennis and Carol, around their 50th wedding anniversary, had a recapitulation of the event, and I was honoured to be the cleric who was overseeing this occasion. So Dennis and I go back a long way. We really met by aggregating around posters at the AGA meetings, where we were attracted to the same posters because we had the same interests. So we got to talk, and we realized that every year we were there together at the same posters talking to each other. And that was the establishment of a very long and warm friendship. We actually co-authored quite a number of papers together in various one form or another, mostly in the form of collaborations. But this one I pay special recognition to and love a lot, because this, I think, was the only paper where we were the only two authors on the paper. And it was addressing mute-associated polyposis, and raising the question as to whether there was an acceleration of carcinogenesis in this syndrome of a base excision repair defect. So as you've heard from Sawadi, Dennis was pretty keen on words. So we constructed this title. I thought he was quite clever to label this paper, Acceleration Colorectal Carcinogenesis, the hare, the tortoise, or the myth. And of course, the myth was reflecting mute-associated polyposis. But it was all about whether indeed there was faster carcinogenesis on the background of this base excision repair defect. I don't think we really came to a conclusion, but at least we raised the issue. Sorry, I'm getting it right now. What I'm particularly addressing, though, is the Aspirin and the United States Preventative Services Task Force recent recommendations on the use of aspirin. And you will be aware that the publication a few months ago in JAMA somewhat downgraded the recommendation to take aspirin. Now, I must point out that in Australia, we have a much stronger recommendation to take aspirin than has been in place here as a result of the previous US Preventative Services Task Force. We did our own analysis some 5 or 6 years ago, which I was the lead scientific contributor to that national and government supported recommendation. We recommended aspirin for all Australians between 50 to 70 years of age, not so much because of its cardiovascular preventative effects, but in fact because of its preventative effects against particularly colorectal cancer. So that in fact is still in place in Australia, that all Australians should take 100 milligrams of aspirin, that's equivalent to your 80 milligram dose daily, for both cardiovascular and cancer prevention capabilities. Not just, and the American recommendation was to focus on people with a 10% or greater risk of cardiovascular disease. So we've stepped one step further. The most recent US recommendation is listed here, that adults between 40 to 59 years with 10% or greater 10-year cardiovascular risk should consider initiating low-dose aspirin for primary prevention of cardiovascular disease, where there is this risk, and the evidence indicates that the net benefit of aspirin use in this group is small, so they've downgraded it from a stronger recommendation to small, And persons who are not at increased risk for bleeding and are willing to take aspirin daily are more likely to benefit. And the task force recommend against initiating low-dose aspirin use for the primary prevention of cardiovascular disease in adults 60 years of age and older. Now, they supported that with a rationale that there was adequate evidence that low-dose aspirin has a small benefit to reduce the cardiovascular risk in people over 40 years of age, and that the absolute magnitude of benefit increases with increasing 10-year cardiovascular risk, and the magnitude of the lifetime benefits is greater when aspirin is initiated at a younger age. They also pointed out the harms of aspirin, which I'll come back to, which of course are gastrointestinal bleeding and intracranial bleeding. And their assessment was that they concluded that with moderate certainty that aspirin use for primary prevention of cardiovascular disease in adults with this greater cardiovascular risk was small, and concluded with moderate certainty that initiating aspirin in adults 60 years of age or older was of no net benefit. Now, it's my colleague and friend Andy Chan from Massachusetts, from Massachusetts General Hospital, who published not so long after that, in July, a somewhat counterpoint, and he headed it, and I'm sure some of you would have read it, Aspirin and the US Preventive Service Task Force, what about cancer? So indeed, he said, unfortunately, the US Preventive Task Force opinion was largely based on a narrow interpretation of new primary cardiovascular disease prevention randomized controlled trials with limited evidence relevance to colorectal cancer, failing to consider the broader evidence base supporting aspirin's efficacy for colorectal cancer prevention. And in its efforts to offer simplified, broad-based recommendations, the task force may have instead muddied the waters, thereby impeding progress in defining the appropriate role of aspirin for colorectal cancer prevention, a missed opportunity in the field of cancer prevention. Andy and I chatted about this before he went ahead and published this. I had some other things to say about it, which I'll point out shortly. So the task force did a pretty standard approach of assembling the evidence. They looked at the benefits, potential benefits and harms of aspirin. And their PICO questions was, does regular aspirin use in patients without known cardiovascular disease reduce cardiovascular disease and colorectal cancer incidence and mortality or all-cause mortality? So they did have a colorectal cancer lens on it. Does the effect vary between our priority subgroups defined by age, sex, 10-year cardiovascular risk, diagnosis of diabetes, etc.? And what about the dose? And then they also addressed the potential issue of harms and whether those harms varied by the dose or duration of use. This is their main table, and it does show the comprehensive nature of the work that they undertook. If you look here, this is not just, these are representing an accumulation of quite a large number of studies that address the particular questions that were being asked. So you can see 10 studies were addressing major cardiovascular disease events and so on. Each of these, they could extract information from quite a large number of studies involving quite a large number of people. And here you can see the forest plot, which indicates, you know, if you look at this, to me, there's still a substantial benefit, favours intervention for all of these cardiovascular events. And if you look at colorectal cancer, you can see that there is benefit, but most of the benefit is only evident from the studies that have a long-term follow-up beyond 10 years. And that's not new, that is not new news to us in the field. We know that you don't see the preventative effects till at least 10 years after the exposure to aspirin. And here you can see it reflected in these data. But they focused a lot on the shorter term studies, which did not show, have not shown such a benefit. And of course, we all know about the harms of taking aspirin. which no one can doubt, although I think that drilling in onto this information, and I'll show this later, the harms, in fact, in terms of mortality associated or fatality associated with these side effects is virtually zero. So sure, they occur commonly, but they're not serious enough to impact on mortality from those side effects. Oh, what do I do now? Go back. Okay, maybe I pressed it too high. Go down here. There we go. So I wanted to, one of the trials that they did put a lot of emphasis in task force analysis was indeed a trial, that's what he said I've been on the steering committee of. This is an Australian trial, the Aspirate randomized controlled trial. This was initiated by my colleague, John McNeil, who recognised that there was a gap in the information relating to older people, 70 years and older, and the effects of aspirin in that group of people. Most of the evidence about prevention, which I'll mention a bit later, came from people 50 to 70 years of age. So there was a gap. That's why he initiated the Aspirate trial, which was a randomised controlled trial of low-dose aspirin in healthy elderly people. And the endpoint was a complex one of disability-free survival, which took on board not only cardiovascular and indeed cancer events, but also a parameter relating to mobility and general wellness. You can see nearly 10,000 people were randomised into the aspirin and similar number to placebo. And it was recruited through general practice. About 3/4 of these were from Australia, southeastern Australia, and the other quarter were from the United States. And this was an NIH-funded trial. It's come out with a number of publications in the last few years, and disappointingly, the outcomes of this trial were negative. That is, there was no impact on the primary outcome of disability-free survival in the healthy elderly, and there was no. And if you look at the subgroups with respect to cardiovascular disease, there was no benefit in cardiovascular disease, and they also found no impact on all-cause mortality, if not a slightly worse impact on all-cause mortality. With respect to, now here you can see it graphically, absolutely no impact on the primary outcome of disability-free survival. But like the other studies, there was an adverse impact in terms of serious bleeding. So that has been quite an influential study. Here you can see, again, a forest plot. And I like to, generally you can see there's no impact on any of these subgroups of patients that were analysed. But if there was any impact, there was some impact on African Americans. And one of the features of the Aspirate trial was they accepted African Americans younger than 70 into the trial. They accepted them from 65 years of age and older, and a lot of the African Americans were in that group. And there was another interesting parameter there in that there was a suggestion that those that were already on aspirin prior to engaging were more likely to have a benefit, although again, not statistically significant. So if you started aspirin before 70, the adverse events didn't emerge, which again points to the age-related benefits and risks of taking aspirin. Here you can see the myocardial infarction and ischemic stroke relationships in graphical form, absolutely no benefit at all. Death from all causes, a slightly worse impact, just significant from taking aspirin, and death from cancer, sadly, for the aspirinologists amongst us, was statistically significantly worse. The types of cancer were of some interest. So I sit on the adjudication committee of the cancers occurring in the Aspirate trial, and the most cancers we see is colorectal, or a large number of colorectals, although The others, of course, are there, but colorectal dominates it. And in fact, the adverse outcomes from colorectal cancer really carry the all cancer index into statistically adverse outcome figures. You can see that represented here in the confidence intervals for any cancer and for colorectal cancer, whereas all the others were not significant. Interestingly, the adverse outcomes in terms of any cancers was largely restricted to those that had advanced cancers at the time of diagnosis in the Aspirate trial. So there wasn't a signal in terms of lack of effect of aspirin where it was diagnosed in early stages. It was when the cancers were diagnosed at stage 4 or metastatic that the adverse aspirin effect appeared. So once again, supporting perhaps that this is not reflecting an effect on early cancer where it may well be preventative, and we might see the benefit at a later time point, but it did seem to unmask progression to advanced cancer by taking on aspirin in these elderly people. And I should point out that the time of analysis of this whole Aspirate trial, the mean time was 4.7 years. And as I've said already, the benefits don't emerge until 10 years for prevention. So there's a serious caveat around the utility of the Aspirate trial in terms of its short analysis. It is ongoing and it has attracted further funds to carry it through to a longer time point. But I don't think we can pay all that much attention to the Aspirate trial because of its short-term outcome, but it was heavily influencing the US Preventative Health First Task Force's recommendations. There was, as I stated, adverse outcomes in terms of GI bleeding from taking aspirin. You can see that's the GI bleeding rate in blue in the aspirin takers compared with the placebo takers. But interestingly, there were only 2 deaths in the whole study from gastrointestinal bleeding, and they were both in the placebo group. So the authors of the Aspirate trial said aspirin use in healthy persons did not prolong disability-free survival over a period of 5 years, but led to a higher rate of major hemorrhage than placebo. And the use of aspirin did not result in a significantly lower risk of cardiovascular disease than placebo. Higher all-cause mortality was observed among apparently healthy older adults and was attributed primarily to cancer-related deaths. In the context of previous studies, this result was unexpected and should be interpreted with caution. Now, there have been some other trials that were assembled in the task force. This one, the ARRIVE trial, was a trial in people at moderate cardiovascular risk taking 100 milligrams of aspirin versus placebo with vascular events as the primary outcome. And this trial too was a negative trial in terms of the primary outcomes of myocardial infarction, stroke, cardiovascular death, and here cardiovascular death. And once again, there was a statistically significant increase in gastrointestinal bleeding, not fatal, but enough to get you into hospital. So that, of course, played into this task force analysis. The Ahnen trial was in diabetics in the United Kingdom, and they were studied for 7.4 years, getting a bit longer. And here the serious vascular event outcome was preventative slightly. You can see that the confidence intervals don't overlap one. And so there was a benefit in terms of serious vascular events in a preventative sense. And here you can see that the events were evident right across the timescale of the 7 years, with the overall benefit being reflected here or in a different form to the graph here. However, they concluded that the absolute benefits were largely counterbalanced by the bleeding hazard. The same trial, the Ahnen trial, here we go, was further analysed here with various sub-elements. And you can see that the benefits in terms of cardiovascular disease were spread right across the different parameters of myocardial infarction, stroke, intracranial hemorrhage, vascular death, excluding intracranial hemorrhage, and serious vascular events excluding TIAs. The whole lot were showed a benefit of taking aspirin in this diabetic population, which they counterbalanced with the adverse events, which were 50% higher. A large trial in Japan, published a little earlier, was also interpreted as largely a negative trial. Here, the trial is for primary prevention of atherosclerotic events in people with type 2 diabetes, the JPAD trial. And the benefits of taking aspirin were there, but not significant. And here you can see a subgroup analysis according to subgroups at risk. All of the effects are on the favourable side of aspirin, but none of them reached statistical significance. And again, there was an array of side effects, not large numbers, these are individual numbers, but in balance, there were more in the aspirin group versus the control group. Interestingly, there was a post hoc analysis of the cancer incidence in the Japanese trial. This is the overall trial, but here's the sub-analysis, which wasn't presented graphically, which showed that there was prevention against cancer with a hazards ratio of 0.67, that is a 33% reduction in those less than 65 years of age. So some evidence of benefit against cancer in the Japanese trial. So once again, getting back to Andy Chan, who analysed all this and considered that the evaluation of the evidence didn't really reflect the benefits against cancer, for preventing cancer. So this may be summarised that in 2016, the task force did recommend low-dose aspirin prevention of cardiovascular disease in those at 10% risk and prevention of colorectal cancer. The analysis of the trials that I've just mentioned, Andy Chan coming out with a question about this, raising the issue that the follow-up in all of these trials that have just been added to the task force considerations were of short duration in terms of follow-up, and that there was a heavy emphasis on the Aspirate trial in terms of the task force recommendations. In my discussions with Andy, we did indeed identify these points, and the persistent mention of intracranial hemorrhage, but no mention of the protective and preventative events against thrombotic strokes. You might be aware that thrombotic strokes are more common than hemorrhagic strokes. So the overall benefit of taking aspirin against stroke altogether is very favourable, given that thrombotic strokes are more common than hemorrhagic strokes. And there was no consideration of the lack of effect on mortality from hemorrhage, and no consideration of the vast amount of supportive observational epidemiology for cancer prevention by aspirin, and no consideration of the CAP2 trials. So what about the 0.67 benefit seen in the JPAD trial, hazard ratio? What about the Women's Health Study, the Nancy Cook trial, which took 40,000 American women and randomized them to low-dose aspirin versus placebo, and found in average risk women a benefit of 29% reduction? What about the large Harvard cohort studies which universally have shown benefit? What about the evidence of prevention of adenomas in randomized trials with aspirin? And what about the other guidelines around the world, the American College of Gastroenterology, the AGA, the Cancer Council of Australia, our own National Health and Medical Research Council, who still advise the use of aspirin to prevent cardiovascular and particularly colorectal cancer? And what about the subgroups that are overlooked? If you are going to dismiss use of aspirin more generally, perhaps question the Australian universal recommendation. What about early age onset of colorectal cancer that's increasing dramatically? What about serrated polyposis syndrome? What about indeed the syndromic forms of colorectal cancer with a genetic basis? Where does aspirin fit into those groups? Can you simply dismiss aspirin in the face of specialised groups? So aspirin might be considered something of a wonder drug. Many of you might not realise that aspirin in nature, in the agricultural world, in green leafy vegetables, if the plant is salicylate enriched, which is a natural form of the plant, this induces apoptosis, and as you can see here, around invading fungi and deletes the fungus from the leaf and protects the plant from the invasion of fungi. So it induces apoptosis. And with agricultural evolution and the use of chemicals and so on in our food supply has progressively got depleted of salicylates in the green leafy foods that we eat. So we indeed have a salicylate depleted diet compared to, say, 60 or 100 years ago. And you can see that we all know that apoptosis has a major role in preventing us from developing cancers. So that's a hypothesis that is supported by what's happened with the evolution of agriculture. And indeed, it was in Melbourne that the first signal around aspirin, I'm going historically back now, retracing steps much earlier than the recent task force was doing. It was the first signal about aspirin emerged from a study done by Bill Kuhn, who was a colorectal surgeon in Melbourne, losing his eyesight through diabetes, recently died, who turned his attention to classic epidemiological studies as an academic surgical professor, and did the Melbourne colorectal case control study, where he took 1,000 Melburnians who developed bowel cancer and compared them with 1,000 Melburnians who had not developed bowel cancer in an age and sex matched classic case control study. And he, for reasons that he said was almost serendipity, asked the question in his case control studies, what do you take in terms of aspirin ingestion, or what have you taken in the way of aspirin ingestion? And to his surprise, all the controls, or the controls, was taking statistically more aspirin than the cases over the recorded period in the case control study. So that was the first study, the first signal of any type that aspirin might prevent colorectal cancer. Here you can see him with my colleague, Sir John Byrne, who is the primary investigator of the CAP2 trials. And John, of course, was very keen to meet Gabriel Kuhn, given the historical nature of that observation. So this is a slide from some time ago now, but since Gabriel Kuhn's observation, there was a flourish of case control represented in green here, and prospective cohort studies, all of which showed a preventative effect of aspirin or non-steroidal anti-inflammatory drugs for the prevention, in this case, of colorectal adenomas. But we could show you others that show the effect of non-steroidals against colorectal cancer incidence. Interestingly, this one here from Paganini Hill, we often like to point out, was an adverse effect. That Paganini Hill study was done in Californian retirees all over the age of 70. So consistent with our current understanding about the age-related benefits of taking aspirin. I'm stuck again. I think I might just need some help. Not moving on. Okay. Yeah, right, do that. And indeed, not only incidence, but also mortality. But these are observational studies. They're not randomized controlled trials. But nevertheless, all of this vast amount of observational information was not considered in the task force recommendations. Here's John Barron's trial of aspirin in colorectal adenomas, which didn't quite reach significance, but very close. The next round of information came from the post hoc analysis of the randomized controlled trials of aspirin to prevent cardiovascular disease with patients recruited through the 1980s, into 1970s to 1980s, the classic British doctors aspirin trial and the UK TIA aspirin trial, which were primarily looking at cardiovascular endpoints for their analysis. At that time, there was no recognition of the cancer preventative effects of aspirin, but indeed, as a post hoc analysis, once the Kuhn information became available from Melbourne, the Oxford epidemiologists took it on themselves to look at the cancer incidence in the same cohort who'd been exposed to randomized aspirin versus placebo. And indeed, they found that after a 10-year latency period, there was a preventative effect against cancer emerging in the groups that had been taking aspirin. So this is rather remarkable. The exposure to aspirin was some years before, you can see there in the red circle, but the benefits had a latent effect of not appearing until 10 years after the first exposure to aspirin. All consistent, though, with the observational epidemiology. And you can see that they looked at the benefits with respect to duration of aspirin use in the various trials. This took several trials, quite a number of trials that they accumulated. And the benefits were seen with respect to whether there was a relatively short duration of 2 to 5 years or a greater duration of more than 5 years in terms of both incidence and mortality, in this case for colorectal cancer. And when they analysed the various trials with respect to the different doses of aspirin they used, here the higher dose aspirin trials and here the lower dose aspirin trials, there was no difference in the benefit, even perhaps a slightly greater benefit in the low dose aspirin trials here when accumulated together. So the dose at this stage didn't seem to be that important. Here's the trial I mentioned, the Nancy Cook trial in 40,000 US women, average risk women taking 100 milligrams or 81 milligrams of aspirin for 9 years. And the benefit, again, not appearing till just after 9 years when the graphs separated. The PLCO trial, which of course was primarily a randomized controlled trial of screening against prostate, lung, colorectal and ovarian cancer, not where aspirin wasn't the primary intervention, but nevertheless, they also analysed secondarily the use of aspirin versus cancer mortality and found a benefit in the overall cohort analysis of people taking aspirin, be it whether it was 1 to 3 times per month or 1 to 2 times per week or more than 3 times per week. There was a benefit which was statistically significant overall. And here's the data with respect to colorectal cancer in particular, showing the same benefit. So somewhat before the recent task force, an analysis of the randomized controlled trials against death due to cancer in 7 trials, here represented with aspirin in red and controls in blue, showed a benefit which was statistically significant. Now, getting back to the risks, this is the data that emerged from the earlier cardiovascular trials done in the 1980s, 70s and 80s. And again, the same adverse event of serious GI bleeding, statistically worse, doubling in the aspirin cohort, aspirin takers versus the control takers. But I always like to point out this one, which is fatal gastrointestinal bleeding, which I mentioned before, where there was absolutely no difference in the placebo versus the aspirin takers. So you bleed, but you don't die from the bleeding. If you're older though, the adverse events increase, particularly with respect to GI bleeding, once you get over the age of 70. So once again, age is a major discriminator, both of benefit and risk. Hemorrhagic stroke, again, an adverse event, but it's a small risk and it's countered by the protection from thrombotic stroke. In the older trials, all cancer mortality was universally favourable with respect to taking aspirin, and indeed all-cause mortality in the older trials showed a benefit. It's pretty hard to get an all-cause mortality benefit from any sort of intervention, but the analysis of those older trials did show that. I like to show this slide, which was done by Jack Cusack, which is a way of demonstrating the risks versus benefits of taking aspirin to our patients, where here is demonstrated 100 men and 100 women who would take aspirin for 10 years starting at the age of 55, broken down between men and women. And what's described here in the different colours is the outcomes with respect to cancer death, not avoided by taking aspirin or avoided by taking aspirin, death due to myocardial infarction, not avoided by aspirin or avoided by aspirin, death due to strokes, death due to GI bleeding and peptic ulcer, unaffected and caused by aspirin, and death due to all causes, and the balance of the people that are alive. Here you can see the benefits of taking aspirin represented in blue for men and women with respect to cancer deaths. It's not large, but it's finite and it's observable. If you compare that with the, and here you can see the deaths from myocardial infarction avoided by aspirin. And the importance here in my mind is that the benefits against cancer dominate the benefits achieved against myocardial infarction. So it's a much stronger benefit for cancer prevention than myocardial infarction. And if you look at the risks, here is the effects of deaths due to stroke, GI bleeding and peptic ulcer, a much smaller slither in the pie compared to the benefits. Now, just before I finish, I want to focus on the CAP trials, which I've been the international co-investigator with Sir John Byrne. There are two CAP trials. One is pretty well done and dusted. That's the CAP2 trial. And it takes the view that a susceptible population such as Lynch syndrome carriers, like canaries in the coal mine, can give us an index of the benefits or indeed the harms of some sort of intervention. So as you know, the canaries in the coal mine are used to identify methane in the gas of coal mines and signal to coal miners that they need to get out of the coal mine because the canaries are falling over. So indeed, we can take populations such as Lynch syndrome and identify reciprocally whether we can achieve a benefit from looking at this highly susceptible population. So the CAP2 trial recruited from 43 centres around the world, and most of them were in the United Kingdom and Europe, but we had a nearly 20% contribution to the CAP2 trial coming from Australasia or Australia. And in brief, the CAP2 trial at its initial 10-year time point, and here I can emphasise the benefits in this susceptible population don't emerge at 9 years, they emerge much earlier than that at 4 years. You can see the benefit. And indeed at 10 years, there was a statistically significant benefit in terms of time to first colorectal cancer in the aspirin group compared to placebo. So this is not quite significant in an intention to treat analysis. In the per protocol analysis, however, where there were significantly fewer colorectal cancers, and you'll understand that intention to treat analyses are more rigorous than per protocol analysis, but nevertheless, they do tell us something. And if you took not only the first cancer, but all cancers, and you'll recall that Lynch syndrome cancers, people frequently develop multiple cancers, then there was a much stronger signal in the group taking randomized to aspirin versus placebo. Now, the dose we used in the CAP2 trial was 600 milligrams. And I remember the conversation with John Byrne about what dose should we use. And we thought that we would push the dose to the highest level that we could reasonably ask people to take who were healthy and well. So 600 milligrams, which is 2 common Aspirate tablets that we usually buy over the counter for headache, taken daily. And although there was no benefit for the first-time cancer, if you looked at first-time Lynch syndrome cancer, both colorectal and any Lynch syndrome cancer, at 10 years, there was a statistically significant benefit on an intention to treat basis. Stronger if you looked at a per protocol basis. Amazingly, when we analysed this at the 20-year follow-up mark, and you'll understand that these people were exposed to aspirin only for 2 to 4 years, the benefit for protection against colorectal cancer or in the top lines and Lynch syndrome on the bottom lines, either on an intention to treat or a per protocol basis, was still evident 20 years beyond the exposure to aspirin. So this has a long latency period of benefit of taking aspirin, in Lynch syndrome at least. No effect, however, on non-Lynch syndrome cancers, so it seemed to be having its effect on microsatellite unstable cancers. So we considered this trial, and it's been taken favourably. It's now written into most guidelines around the world for Lynch syndrome carriers that they should be taking aspirin. The dose, however, is still uncertain. You've seen that earlier analysis where there didn't seem to be much difference in the dose, whether you were taking a low dose or a high dose. So the CAP3 trial, which is now 50% through its journey, has randomised randomised Lynch syndrome carriers to 100 milligrams versus 300 milligrams versus 600 milligrams of aspirin without a placebo arm, because it would be unethical to introduce a placebo arm into the current trial. So it's taking 3 doses of aspirin and evaluating the outcomes. This includes not the 900 carriers that were in the CAP2 trial, but 1,800 carriers from the United Kingdom, some from Europe, and again, quite a large cohort from Australia. So I'd like to finish here, Sawadi, acknowledging a large number of people that have contributed in various ways to this journey about aspirin, from our own teams in Australia and, of course, our collaborators in the CAP trials, particularly in the United Kingdom. And I'd like to thank you once again for this wonderful opportunity to acknowledge Dennis's contribution to the field of gastroenterology, not only here at the VA in Denver, but with a penetration that's been right through the world, and which I in particular have very warm memories and appreciate and have appreciated so much over my lifetime's association with my dear friend, Dennis Ahnen. Thank you.
Standing. Thank you very much, Dr. Mcrae. We do have time for questions. And we welcome questions from our virtual audience as well as our in-person audience here. I can start with a question. Can you talk about the differences observed in the Aspirate trial among African Americans or African descent individuals, and why you hypothesize there was a different scene and outcomes?
I'm not quite sure I can give a complete answer to that, but the answer on the top of my mind is that they were younger at recruitment by protocol design, and therefore reflect the age discrimination in benefit from taking aspirin. So they were younger than the white populations, and that would be my first answer. Whether there's a genetic basis to the benefit in African Americans versus whites, I'm not sure. I don't think we know the answer to that.
Take a question from the audience from Dr. Marie Wood. Thank you for joining us. Please introduce yourself. I think you're new to our audience.
Sure. Thank you. I'm Marie Wood. Recently come back to the University of Colorado, where I helped to start the cancer genetics program with Dennis Ahnen. So it's a great honor to be back here. But I've spent a lot of time since I've left working in prevention. And I have two questions about the Aspirate trial. One, to what degree do you think the negative effects are the fact that we've started aspirin so late in life? It seems to me that if we're going to prevent cancer, we need to do it earlier. And my second question is about mechanism. When we see a demonstrated effect in Lynch and other very high-risk populations, to what degree do you think it's the mechanism of cancer development? I know those are two disparate questions.
Yeah. So I'll get the first question again.
The first question again has to do with, we started so late
Yes,
in the
yes,
Aspirate
yeah.
trial.
Yeah. Well, the Aspirate trial deliberately started late because John McNeil recognized there was a gap in the information relating to aspirin. And of course, it wasn't just about cancer prevention, it was cardiovascular as well. So he wanted to plug that gap. And I know that when we framed the Australian recommendations for the population before the Aspirate trial was anywhere near complete, we recognised we might get shot in the foot if the Aspirate trial turned out to be negative for people over 70. So we deliberately restricted the advice for Australians to take only between 50 to 70 to take aspirin for both cardiovascular and cancer prevention. Given the latency of 10 years for cancer prevention, if you start taking it at 70, you're not going to see the benefit until you're 80 or 90. So that's getting a bit beyond the pale, really, in terms of considering it as a benefit. What do you do with people who are on aspirin before the age of 70 and moving into the over 70-year-old age group? And we see that a lot, of course. What do we do with those? Of course, America has a greater prevalence of aspirin takers than we do in Australia. I think there's quite a significant difference in terms of the use of aspirin in America to what we see in Australia. But nevertheless, we frequently encounter people who have moved from their 60s into the 70s and what we do. And based on the Aspirate trial and that information, that there was still benefit, although not quite significant, for the group that were, the small group that were under 70, who were already taking aspirin. I actually advise that they keep taking aspirin, provided there isn't a good reason for them not to take aspirin. And indeed, any conversation I have about people taking aspirin at any age is counterbalanced by advising them of the risks. I tell them if they've got unpleasant indigestion, had a nasty history of peptic ulceration, have got compromised renal function, have uncontrolled high blood pressure, or have an allergy to aspirin in terms of getting asthma, then don't take it. So that's the answer to your first question. It's not really surprising, I guess. And the second, with respect to the mechanisms, well, the mechanisms are not entirely clear of the benefit, but there is the suggestion that it may be a COX inhibition. That was the first thought because, of course, aspirin is a COX-1 inhibitor and COX-1 is expressed in higher levels in a lot of cancers, including cardiovascular cancers. COX has a proliferative drive in its effects and functions, so that's one mechanism. Probably the more prevalent suggestion is its effects on platelets and the role of platelets in terms of enhancing metastases, and that would be supported by the Aspirate trial in terms of the differential worse effect being for more advanced cancers rather than early cancers. So I think the platelets effects are important in terms of the support by platelets for dissemination to metastasis. But I don't think we really are sure at the end of the day about what the mechanism is.
I was also thinking about the mechanism by which colon cancer develops in Lynch carriers, where you see a clear positive effect versus the general population, which has a 10 to 15.
Well, one of the first bits of evidence that supported us going into Lynch syndrome as the population to test aspirin was a paper by Rushoff, who did in vitro studies of the effect of aspirin on cell lines, be they microsatellite stable or unstable. And aspirin indeed stabilised the microsatellite instability in the cell lines compared to, and didn't have an observable effect in microsatellite stable cell lines. So that was supportive, in fact, of us moving in this direction. And it's really interesting that there's no benefit in the CAPS trials for non-Lynch syndrome cancers. So it does suggest that aspirin has a greater effect in protection against microsatellite unstable cancers, which of course are characteristic of Lynch syndrome. But I don't think that's the whole story. I don't think that's the whole story, because if you look at the epidemiology, observational epidemiology, which is coming out in multitudes of papers, the effect is against all cancers, mostly lung cancer, breast cancer, all manner of cancers generally show this preventative effect. Not all, but the vast majority are showing a preventative effect, not just microsatellite stable cancers.
Thank you, Dr. Mcrae. Dr. Brown.
Thank you for being here, Finley. My question is, given that there is an increased incidence of GI bleeding in the aspirin users, is there any effort in the trials to try to decrease or identify the people who might be GI bleeders?
Yes. Well, firstly, exclusion criteria included those that had unhappy histories of peptic ulceration, so peptic prone patients. That would be one effort, or indeed have got the indigestion. So ones that I'm pretty sure they were excluded from the CAP2 trials anyway. In terms of clinical practice, we have a pretty low threshold to co-prescribe a proton pump inhibitor if there's a good reason to take aspirin for chemoprevention. Other than that, the history of the patient, I don't think there's any particular way that we can discriminate the at-risk people from the people are not going to run into trouble.
Dr. Muthing.
Thank you so much for that talk. In the trials that showed benefit for cancer prevention, what was the mean duration of aspirin use? And how did you guys decide on that 2 to 4 year use in the CAP trials?
Second question's easy to answer. What do we get funding for? The first question around the different durations of use in the different trials. Well, as I showed you there, from the earlier trials in the 1970s and 80s using different doses of aspirin, there wasn't a difference in the benefits in cardiovascular prevention and indeed cancer prevention. There is, however, been one probably significant information that emerged from the Oxford group that analysed the benefits of taking aspirin against body mass index or weight. Getting at the question, was there a weight-based dosing that we should be considered for cancer prevention with aspirin? And indeed, the evidence does suggest that you need a larger dose if you're more overweight. So low dose aspirin, 81 milligrams, works pretty well if your body mass index is 25 or less. But if you get above that, you probably need 300 milligrams or 325 milligrams. And we'll be able to analyse that in the CAP3 dose trial very easily, because we've got all the weights and they're on differential doses. So we'll be able to give a pretty good answer to that.
Thank you so much for the fantastic presentation. I'm curious to know your thoughts about the endpoint that was used in the Aspirate trial, which is disability-free survival. I don't think I've seen that before, or at least in too many RCTs that look at chemo prevention. So I'd love to know your thoughts, and is that endpoint going to be replicated in upcoming trials on chemo prevention? And my second question is, with regards to all these trials being done, how many of them have actually accounted for patient-centered outcomes and patient preferences?
Good questions. I think from the patient perspective, in terms of mortality, it doesn't really matter whether it's mortality from cardiovascular disease or cancer, you're dead. So a more universal outcome measure is the appropriate one. And I guess that's what, and if you think of the elderly and their priorities, disability-free quality of life is a pretty important one as you get over the age of 70. So I think that it's a pretty smart endpoint, disability-free survival, that accounts for the things that elderly people are most concerned about, quality of life, as well as the important things that we as scientists might think of, like dying from heart attacks or strokes or cancer. So I think it's a pretty smart one that's relevant to that population in particular. So we might see it used more uniformly. We like to silo our thoughts, I suppose, in terms of cancer and heart attacks and strokes and whatever, but that's not really the patient perspective in the main. And yes, I think we will see more PROs, patient-reported outcomes, because that's really the contemporary, the contemporary context of clinical trials now, to use patient-reported outcomes often as their primary endpoint, albeit less rigorous in terms of the objective nature that we'd like to see for trials often. So yes, I think it's a good question. I think that at the very least, they'll be taken as important secondary outcomes from the trials.
Another question from our advanced endoscopy fellow, Eric Montminy.
Thank you so much for that talk. That was excellent. Have you seen a preferential effect on either colon or rectal cancer? It seemed like every one of these trials summed everything up into colorectal cancer, and seeing if perhaps colon was more affected by aspirin use. I ask because a lot of these early onset or patients approaching average screening index are almost always, most of the subgroups are preferentially rectal cancer rising as opposed to colon cancer.
Yes, there is a distribution benefit, and it's more in terms of right-sided cancers than left-sided cancers. And that actually has been highlighted in terms of colonoscopic screening benefits. And if anything, if there's a deficiency in colonoscopy screening, it's for right-sided cancers, because the colonoscopist doesn't get there. So, and the data suggesting aspirin is more preventative against right-sided cancer, therefore complements colonoscopic screening. So that's a bit sad in terms of your observation that you're right, that the early age onset colorectal cancers are more distal and in the rectum.
Is aspirin more? Have you seen the effect on aspirin as well? Is Has there been any like sub-analysis within these?
Yeah, it's more effective against right-sided cancers than left-sided cancers, which is sad from your observation about the distal increase. Don't know why. I don't know why.
Highlighting certainly more work to be done. So we thank everyone for your attendance and engagement with Dr. Finley Mcrae. Dr. Mcrae, I'll let you have a few final words, but we just extend our greatest appreciation and gratitude for you traveling all the way from Australia to be here for the 4th annual Dennis J. Ahnen Lectureship. Thank you very much.
For Dr. Mcrae. I'm the official photographer. Thank you. Perfect. Dr. Mcrae is visiting on behalf of the VA and the Denver Research Institute, and he'll be giving a keynote lecture tomorrow at 1:30 at the VA hospital. So if you have the opportunity to attend, please do so. And thank you so much for a really wonderful day and a wonderful tribute to Dennis. Thank you all. And thank you for coming. Thank you so much for coming.